Okay, and we're live. That feels like I always feel fun saying that. Hi, everyone. I'm going to spotlight myself for just a moment, just for the recording. Oh, I know it's so good to see you guys. We are so excited to kick off our suddenly last day of Health Equity Week of Action, HEWA for short, here with our first session. I can hardly believe that we are at the end of the week, and quite frankly, there's no better way to spend it than with our presenters today. So I'm going to take a moment to introduce myself, introduce our committee that's been working with these wonderful folks to organize today, and I'll introduce us to the framework of abolition and why we have so chosen this framework, what it's orienting us towards, and then again, why it fits so perfectly that we would have NMDP here with us this afternoon. There afterwards, I will pass the poll and we will hear from our lovely folks, and we will have a chance at the end for questions and Q&A. So thank you. So thank you all for being here. I'll continue to monitor to make sure everyone gets in, and the stream is up and live, so you'll be able to access that as well. So without further ado, hi everyone. I am Danya Amadian. I am your Civic Science Fellow here at AMSA. What that really means is I have the immense privilege of being a part of some fantastic racial equity research work, but also I have the gift of being able to be closely tied to our advocacy arm. And a part of that is being able to put together wonderful weeks like this, Health Equity Week of Action, where we have a chance to pause and invite ourselves to really question what is the healthcare of tomorrow that we are seeking to be a part of. What vision do we have? What vision do we have that's not exactly aligning with the vision that we're seeing today? What can we hope for? And above all, how can we hope in community? So with that being said, our framework for the week is abolition medicine. And I know I've talked about it repeatedly this week. I hope you're not tired of me saying this, because we have to tirelessly, attend to this work. And abolition really just means a call to action, which I've mentioned several times. But what does a call to action mean? It means, how do we utilize our voices? How do we utilize our privileges and speak out against structures of inequity, structures of violence and of harm, structures that give disproportionate access to care, to services, to well-being, to communities that are marginalized, communities that are stigmatized? How do we uplift their voices? Big questions, right? And part of that is being here together. In collaboration with our Code Blue, events that we've been putting on, our Code Blue initiative, we've been really urging the community, both of AMSA and beyond, people that are just finding out about AMSA, we're believing ourselves to be a lighthouse of sorts. It's the symbolism that we've been using, a safe harbor, no matter the storm, no matter whether the waters feel rocky or still, the lighthouse remains, right? It responds no matter what the external environment looks like. The lighthouse is a solid place of refuge, and it calls out that safety. It brings that light to bring people in. And a lot of what we hope here at AMSA with, again, HEWA, with Code Blue, is to ensure that we are being that place for others. And so as we do that, we look for people that can help us do that, right? So I will briefly, and I think we have a little bit of unmuted action going on, and that's fine. I love to hear it. Is that me? It's okay, whoever it is. No worries. Okay, so thank you for that, for unmuting for me, or for muting for me. So now, I want to take a moment to just say thank you to our wonderful committee that's been working so hard on this week. I'm not sure if she's here quite yet. She will be. Our lovely REACH chair, Tanushree, has worked tirelessly on this event. We have students like Stephanie, Michaela, students that have gone out of their way, Mia, to put these events on. Our lovely Jeff, who co-leads our reproductive health arm, has helped to conceptualize this event. Pete, who has worked tirelessly in the background to make sure that we have, all the things going right. And of course, to all of our AMSA staff and community members who have been a part of this initiative. So thank you all, and thank you very specifically to NMDP. So as one of our partners, I am so glad to have the privilege, I'll keep using that word because it truly is, to introduce them here today. They were formerly known as The Match, and of course I'll allow them to introduce themselves as well, but they have worked tirelessly. I keep using that word, but I feel it's so appropriate, to work within a health equity framework, to provide stem cell therapies, to provide access to resources and life-saving care to people no matter their level of resources and backgrounds. And as I mentioned, through this abolition framework, we're working to uplift voices, especially those that are marginalized. And they do such a wonderful job at working to level the playing field. Who gets to receive these life-saving services? Who gets to receive care? How do we make care equitable? So we have a few wonderful staff members that I'm excited to introduce today. And I'll just briefly mention, their names. We have the lovely Lexi, we have Matthew, Rebecca, and Elias, who will first be kicking us off today. So I am so grateful for you guys here. Thank you for taking this moment with us. Thank you for being here. And Elias, without further ado.
Thank you so much. Hopefully you guys can all still hear me well. I'll just look for some nods. All right, nods and thumbs up. Perfect. Well, thank you for joining us today in this important discussion on health equity and cell therapy. My name is Elias Lemon, and I serve as the vice president of belonging and engagement here at NMDP. Now, I understand it's a Friday afternoon, and whether you're participating live or watching the recording at a later date, I sincerely appreciate your engagement in this critical conversation. Lexi, next slide, please. So at NMDP, our mission is to save lives through cell therapy. Every 3 to 4 minutes, someone in the United States is diagnosed with a blood disease or disorder that could be cured through the therapies we facilitate. Remarkably, only 70% of patients do not have a fully matched donor within their family, making our role in connecting patients with unrelated donors vital. Our efforts are dedicated to ensuring that every patient, regardless of their background, has access to life-saving cell therapy. Next slide, please. So, a little bit more about us. We were founded in 1987, and since then, NMDP has grown into a global leader in cell therapy. With a dedicated team of over 1,800 employees, we facilitated more than 136,000 transplants worldwide. In 2024 alone, we impacted 7,994 lives, which was the highest annual number in our 35-plus year history. Our commitment, though, extends beyond just transplants. Through our foundation, we've provided over $6.3 million in financial assistance to more than 3,300 families last year. Additionally, we welcomed over 200,000 new potential donors to our registry, expanding the hope for patients in need. So our mission is clear. We save lives through cell therapy. Our vision is to create a world where every patient can receive their life-saving cell therapy they need, regardless of their circumstances. We believe that everyone deserves a chance at a healthy life, and we're committed to breaking down barriers to make this a reality. So, how does NMDP get this done? Well, our process involves several key steps. First is registering potential donors. We recruit and register individuals willing to donate their cells to patients in need. Then we match donors to patients utilizing advanced tissue typing techniques. We identify optimal matches between donors and patients. Then we do the work of facilitating that. We guide donors through the collection process, ensuring their comfort and safety while coordinating the timely delivery of cells to patients. And then we also support the patients with comprehensive support throughout their treatment journey. But beyond just those steps, research is a cornerstone of the work that we do. In partnership with the Center for International Blood and Marrow Transplant Research, or CIBMTR, we lead transformative studies to advance cell therapy. Our research focuses on improving access, survival rates, treatment protocols, and quality of life for patients post-transplant. By collaborating with a global network of partners, we strive to make cell therapy more effective and accessible to all. take just a brief moment to watch this video that highlights our mission and our work.
Is the volume okay for you guys? Is there a... Sometimes this happens. That's okay. We can't hear it? Okay. Let's see. So worst case, we can always watch it. You can put it in the chat if it's possible. How's it going on your end, Lexi dear? I know maybe like the privileges, you have the full privileges, but I know sometimes that doesn't go through.
I can share it and I can hear it. So sorry about that, everybody. That might be something that I didn't turn on when sharing screen. I apologize. I should have checked that.
Totally
Let me
fine.
see.
Yeah,
Share
take your
down.
time.
Apologize, everybody. Okay. Let's try again.
NMDP is now making donations possible by matching patients and donors, and now making discoveries possible by funding science that's changing the world. So here's the thing. We need more donors, people. Just imagine, no more denied patients. New matches diligently paired. New medical treatments developed and perfected. Your donation changes lives, and you're now making dreams possible. NMDP. Find cures. Save lives.
Thank you for that. I'm glad you guys could hear the audio on that because the video is much better with audio. But thank you all for allowing me to set the stage today. I am honored to introduce today's esteemed presenters. Again, we have Lexi Hopkins, who serves as our Health Equity and Engagement Partner, Dr. Ron Jacob, who is our Director of Member Recruitment, Rebecca Garber, who is our Strategic Partnerships Director to the U.S. and Mexico with the NMDP Foundation, and Matt Kroger, who's the Senior Manager of Programs and Partnerships with Member Recruitment. And with that, I'll turn it over to Lexi to continue our discussion.
Thank you so much, Elias, for that wonderful introduction and sharing the work that we do. So this is a brief agenda of what we're going to be talking to you guys about. We're going to go through some history, talk about health inequities, talk about health inequities in transplant, and we have some interactive components. So be ready to get your phone out, scan a QR code to participate. It's 100% anonymous. We want you just to feel engaged and like you're part of the conversation. And if you're at home and watching the recording, you are welcome to take a pause and do the questions yourself and think and reflect of how you would contribute to it. And we'll kind of end talking about NMDP's work and what partnership means to us. And so I want to start also with some ground rules. So I'll let you all read through these, but as a disclaimer, we're going to be tackling some heavy and charged topics today. And it's unfortunately the reality of kind of the history of health inequity. And I will do my best to be gentle, but real in presenting these topics with you. I want everybody to know that nobody in this virtual room today or watching the recording or in the future is responsible for the acts of their far distant ancestors or any close family members' actions. But we are all responsible, especially you as burgeoning healthcare professionals, for continuing to educate ourselves and being part of the solution. And so today is just one step in that direction. And so we'll start by talking about the roots of health inequity. So my background is actually in history. I'm a historian first, and then I say public health practitioner second. And my research really looks at the history of health inequity, starting from the slave trade all the way until modernity, and really understanding why we're in the situation we are today. So I'm going to walk you guys through some of that really rich history. It's not comprehensive. I would love to talk to you for hours and hours about this, but that's not the time we have today, nor what this presentation is about. So I'm just going to highlight a couple examples of what we can think of. But before we start, I want to interact with you guys. So please go ahead and scan this QR code, or you can go to www.menti.com and enter this code 11830463. And what you'll do is you'll get some questions and we'll go through these questions together. So I'm going to switch over the screen in 1 second. And you'll have a second to still scan the QR code while I switch, so do not worry. Great. So we're going to go through some questions. And again, this is completely anonymous. There is nothing that will be shared with anybody. Your name will not pop up. So please don't worry. Answer as honestly as you can. So to begin, when you think of healthcare, what do you think of? Think as broadly as you want. And you can submit as many responses as possible. And I'm going to let the numbers kind of add up as people are submitting. Okay, great. We got some answers. So people are thinking about insurance, gentleness, doctors, compassion, holistic care. Wonderful. Somewhere you go to get answers about your health. These are wonderful answers. So I'll move it to the next one, and your phone should automatically switch to the next screen. So have you personally experienced bias or discrimination within healthcare? Okay, great. So we see some yeses, some nos. And then do you know someone who has experienced bias or discrimination within healthcare? Great. Okay, I'm going to switch back. Don't answer this one just yet. But as you can see, we've all had different experiences. We all come to the table with different experiences, different knowledges, and we think of different things when we think of healthcare. So I'm going to start with this historical component. So this excerpt is from the 1815 book, The History of Smallpox by Dr. James Carrick-Moore. He was a surgeon or doctor on a lot of the slave ship excursions that happened in the West, as the United States and South America and the West Indies were being colonized. And so in this excerpt, it says Hispaniola or Santo Domingo was the first settlement founded by Columbus. This is Christopher Columbus. After he was gone, numbers of adventurers, that's the language that was used for those that were settling new land, who were colonizing new countries, flocked thither, whose hearts were hardened by avarice and fanaticism. So they had big dreams, right? They wanted big adventures. In addition to that, they had experienced hardship and they were already kind of hardened. The safety of the Indians, that's the Native Americans or the natives to that land, never entered the thoughts of these men. And it was ascertained that the smallpox and measles were carried to that island in the year 1517, though the individual who committed this atrocity was unknown. Prior to the 1500s, we don't see any formalized healthcare system in Europe or definitely in the United States or in the West Indies. The reality was that healthcare was something for the wealthy. It was the wealthy were able to access doctors, and often it was more so apothecaries and pharmacies. And for those that did not have money, they went to local healing people, often women. It was a very female-dominated field. And they relied on natural supplements, herbs, and holistic remedies to abate their illnesses. Once we see the expansion of colonialism and different systems of change, we notice that a lot of these illnesses are now being passed across populations who had never come in contact with these types of diseases before. There was no natural immunity or any exposure to it in the past. And so what was happening was with native populations, they were being exposed to diseases they had never seen before. And the result was that large swaths of tribes, individuals were killed and died by disease that they had never encountered. And the reality was that their health was never considered in this epidemic of colonialism. And so what we see, though, too, is that a lot of narratives become to be formed about the identity of natives in their land. They were seen as weak, as having weak constitutions, the inability to work. And I share this not because, it's something to sit with and to really struggle and to consider in today's language. But the reality is that's how the first perceptions were formed, and a lot of those threads are seen throughout. And so with that, I want to move on to thinking about how that flows into slavery. So the original ambitions were to enslave the natives, to cultivate and colonize the land, and to tame the land in the United States and the West Indies. But with all the illnesses that the individuals faced, Native American individuals faced as they were being colonized, the European colonizers had to shift their focus elsewhere, and so they turned to West Africa. And so this is a description of a slave ship. It's a schematic of what a slave ship looked like. As you can see, it is very packed, side by side, head to toe. People were packed into these slave ships and made to survive in these dark, dingy conditions for up to 9 months. In addition to the fact that these ships were not waterproof, they're drifting in water, there's water that's coming through, there was high levels of dysentery, unsanitary conditions, and people were dying of illness. And in addition to that, these bodies would stay there for long periods of time until they were cleared out. What was faced on top of these horrors, the slave ship captains were faced with this question of how do we keep people alive enough to transport them from West Africa to the United States, to the West Indies, while also keeping the minimal cost allowed. And so to do this, they turned to pharmaceutical companies. As I mentioned before, we didn't see a big pharmaceutical industry at this point. Instead, we were really thinking about small family-owned apothecaries who didn't really go outside of their local communities. But with the wave of slavery and increase in slave ship expeditions and the increase in the slave trade, we now see that these pharmaceutical companies have the opportunities to make a lot of money and to have these big contracts with slave ships. And so these pharmaceutical companies, there's a lot of really interesting documentation. It's almost like a telenovela. It's very dramatic. They were burning each other's shops down. They were fighting each other. There was like executions, almost like a mafia movie around, how do we get these contracts? How do we make this money? And so when we think of the pharmaceutical company and industry today, there's a lot of debate around the capitalism, the competition, the costs of drugs. And so I share this example to think of like where it all started. Because the second these pharmaceutical companies, now that we think of them, in reality, they were small local pharmacies, right? Got these contracts, they had to industrialize their production. So instead of the herbs that they were selling in the small batches, where they're telling people to brew teas, drink it, and do these long processes, they had to think of more fast-acting drugs that could be easily transported and could hold for longer periods of time. And so I share this to kind of share how we think of like the birth of healthcare in America, the birth of this healthcare system comes on the backs of trying to keep people alive for almost nefarious reasons. And so, as I said before, there are so many examples of the ways in which history and medical inequity intersect. But I wanted to share some additional quick examples. So on the left, you see statues from Montgomery, Alabama, and these honor the women, Lucy, Anarcha, and Betsy. And they were just three of the numerous women of Black enslaved women that Marion J. Sims, he was a physician, experimented on to really advance the gynecological field. They're considered the mothers of gynecology because they were experimented on without anesthesia to further this field and are often not credited for the sacrifices they made to our modern medicine. The second picture you'll see is the practice of dissection. And this is something that still happens in medical schools today. You will have the opportunity, if you're not in medical school, to do cadaver dissections. And the reality is that this practice began with grave robbing. People would rob the graves of those of lower socioeconomic status, of Black individuals or marginalized populations who did not have the opportunity to advocate for themselves or to go to those in law enforcement or in power to request the bodies of their family back. And there's a lot of debate about this today. We've seen in the news that over the last 2-3 years that oftentimes incarcerated individuals or disenfranchised individuals, our bodies are being donated to science for cadaver dissections without the consent of themselves or their families prior to their death. And then the last picture is that of Henrietta Lacks. This was in the news last year quite a bit because her family finally received reparations. In the 60s, Henrietta Lacks was suffering from cervical cancer at Johns Hopkins, and she went for treatment, and her cells were collected by a physician. physician noticed that the cells were rapidly increasing and replicating. And to this day, HeLa cells are used in wet labs and research across the world. Not only did this make Johns Hopkins a lot of money, but Henrietta Lacks lost her uterus in this process. Her family was left just knowing that her cells were stolen and she lost her uterus, and were never given reparations or financial compensation for their loss or the medical malpractice that happened. It wasn't until the book, The Incredible Life of Henrietta Lacks, was written and a reporter really dug into this history that attention was being brought to this issue. And it wasn't until 2023 when her family finally received some compensation for the struggles that they had faced. And so what this shows is how advancements in healthcare came at the expense of Black and Indigenous lives, dignity, personhood, and consent. So let's take a pause. I know it's a really heavy history. That's part of why the ground rules. There was a second to commit to self-care, but I just want to hear your reactions. So I'm going to go back to the Menti again and give you guys a second. So it's still the same link. It should work if it's up on your phone already. But I just want you to reflect. How do you feel after learning about the roots of health inequity in the United States? God, yes. Ready to make change, frustrated, devastated, angry, afraid, yes, skeptical, discomfort, sickened, afraid, bothered, frustrated, enlightened, yes. Thank you for sharing these words. Okay, we're gonna pause again. Don't do this one. And so I share this with you, not to scare you and not to make you feel dejected, but to bring to the reality that health inequity isn't an issue of the past. While I share this rich history, we know that the impacts are still felt today. And the reality is that you all have the opportunity to make a change in this. So here are some stats on race-based health disparities compared to non-Hispanic white disparities. So these statistics, this history, it's hard to hear. It's a hard reality to face. And especially given the fact that we are spending trillions in healthcare in this country, right? We question why, with all the money we're spending and all the progress we have made as a society, why is this still happening? And the reality is this is very, very complex. So we know that racial bias in medicine is real. So with these points, even if you have never witnessed or experienced it, and it might be hard to conceptualize, the examples are countless. There's plenty of research studies that dive into the ways in which there's racial bias in medicine and the ways in which our own biases counteract the treatment we provide as providers. And we know that race has impacted our health system in so many ways, from pain treatment to thinking of who deserves treatment and who does not, to thinking of who is drug seeking versus who is in actual pain. And it is in biases and inequalities like this that cause disparities. Medicine is simply just not objective. It's an art as much as it is a science. You guys are learning the art of medicine. And simply, there will be pitfalls. There will be shortcomings. Your own lens will get in the way sometimes, and that's okay. But when we're aware of it, we can adjust for it. We can account for it. We can bring in other people who have a different lens than us to do better work. And on top of that, these systems, they're built to be difficult. They're built to have a little bit of a fight that we all have to put together. On the left, I share a table of some of the misrepresentations of race in preclinical curriculum. And, I just point out that it's, again, not the fault of the individuals. It's these systems we're up against. These are things that are taken from textbooks that are misinforming individuals that we have to point out and call out so that we can adjust and educate ourselves, our peers, and our colleagues. And beyond the reality of healthcare being a big driver for inequity, the other part is that 50% of a person's health can be traced back to where they live, and the other 30% is health behaviors. Where you live is one of the biggest determinants of your health. We call these the social determinants of health. Social determinants of health can be divided into 5 categories: economic stability, built environment, education, community and social context, and then lastly, the healthcare system. So it's more than just what experience you have once you go into the doctor's office. It's also your experiences outside of a healthcare setting. When you think of these social determinants of health, they can positively or negatively impact your health outcomes. And the reality is inequities, which are the disproportionate distribution of resources that are avoidable, unfair, and unjust, manifest as disparities. These are the preventable differences in the burden of disease, injury, and violence. And so when we hear about equality, that's often commonly used language, we're thinking about providing the same and equal resources without considering individual needs. And this is typically tailored to the dominant class, race, culture, creed, ability, and gender. And in this picture, you can see here, everybody gets the same exact bike, no matter their size, their ability, or the terrain they're on, right? And we know that that doesn't work. Equity, on the other hand, though, means providing tailored support to fit the individual need based on the individual circumstances. So the child gets a child bike with treads because they're on a bumpy surface. This man, he still has the same bike because it was working before. And this woman not only has a wheelchair, but a power wheelchair. The bike is removed and she can go up the ramp with ease. So I'm going to hand it over to Dr. Ron Jacobs to talk a little bit about health inequities within cell therapy now.
Thank you so much, Lexi. So I am thrilled to, I just have to say, I'm thrilled to be presenting to this group. I was a AMSA member myself many years ago. When Matt told me about this partnership, I ran into my storage closet and found my old AMSA t-shirt, and I pulled it out and took a picture and sent it to our leaders. I think they are using it against me, but I am thrilled that we have this partnership right now. I have to say, one of the beautiful things about NMDP is we are a multifaceted organization that from the beginning of the education process and the enrollment of the members to the registry, we support them all the way to the end. With the collection, with the transport and the couriers that are volunteers that take these cells to our recipients. We support the donors, the patients, the recipients. Another wing of ours are those studies that we do and the medical advances. And I am thrilled to discuss in some later slides the medical advances due to these NMDP studies that will better serve marginalized populations. Next slide, please. But despite these advancements, we know that many patients still aren't able to access life-saving care to these available opportunities. I started many years as a volunteer. Because I had a very good friend of mine who I was friends with since the age of 5. And in our mid-20s, I was a second-year medical student, and he found out that he was diagnosed with leukemia. And it was because of his diversity that he did not have readily accessible donor in the registry. And we know that is still a fact to this day. We can go to the next slide. So we understand access to transplant is complex, and in healthcare in general, the opportunity is often based on race, ethnicity, socioeconomic status, amongst other factors. And for my friend, it was his race and ethnicity. But we know for many people, it goes beyond that. It's sometimes age, it's sometimes where they grew up. And these are the things that we at NMDP are trying to address right now. Next slide, please. There is a difference of 11% between an ethnically diverse patient's likelihood of going to transplant versus a white patient. So if you look at these numbers, a white patient who is diagnosed and with a transplantable disease, you see the numbers, will ultimately they'll receive a transplant 42% of the time. Whereas if you are ethnically diverse, that number drops to 31%. This is where we at NMDP are working to ensure there's an equitable solution to this. Next slide, please. So there are multiple reasons and multiple obstacles that ethnically diverse and racially diverse patients face. First one is insurance. We understand and know that non-white patients are less likely to be insured. We understand that Black patients are more than 2 times more likely to not be referred for transplant versus a white patient. And we know access is a major issue as well, that patients from diverse backgrounds were more than 50% less likely to receive an allogeneic hematopoietic stem cell transplant compared to other non-white patients. And then there are those systemic barriers that consistently exist, right? We know that diverse patients face these structural, financial, and ethnic cultural barriers to care, which can erode the trust in the medical system, which, as Lexi mentioned, has eroded the trust in the medical system. And that's something that we at NMDP acknowledge and work with. And as we advance, we have that as our baseline. Next slide, please. HLA. The beauty and the magic of HLA matching. Now, I'm going to explain HLA to you the way that I do to non-medical professionals. So I apologize if it's in a simple form, but but this is how I try to explain it. We understand the blood typing, ABO positive, negative. HLA is a little more complex because HLA is what is human leukocyte antigen. It is a protein that is found on all your cells. It is what identifies self against non-self, right? And that's how the body will reject. Now, for us, HLA is what we use to match a recipient with their donor. The simplest way I always explain it is you have a unique HLA typing. Let's say there are 8 antigens within your body. You've received 4 from your mother, 4 from your father. That is your unique HLA typing. Most of the time, 70% of the time, patients need a donor who is not related to them. And that is where HLA comes in. HLA is driven by race and ethnicity, and we understand that. It is complex and it is difficult to find a match. But these advances have made it a greater opportunity for us to be able to serve ethnically diverse patients. Next slide, please. The registry itself does not have enough diversity right now. And that is the honest truth. We are doing everything and anything in our power to build up partnerships and establish these connections with ethnically diverse groups across the country. But we know there's work to be done. Only 13% of the registry identifies as Hispanic, 8% Black or African American. Only 9% within our Asian Pacific Islander Native American back group, and only 1% identify as Native American. Simply put, we need to do better at increasing the committed and available donors who are of ethnically diverse backgrounds. Next slide, please. And again, we've discussed this. Patients from lower socioeconomic backgrounds face multiple hurdles. One of the things that we've realized is individuals living in higher poverty rates are less likely to receive an unrelated donor transplant. But we've also found, and our studies have shown, that poverty level, race, ethnicity do not affect long-term outcomes among patients who proceed to transplant and survive at least 1 year. So that suggests that it's the initial access that's key for these patients. So when we take a look, we realize that 73% of these recipients report a financial toxicity. These are the areas that we need to support our patients. Next slide, please. And I believe we are going to pass it along to my colleague, Rebecca Garber.
Wonderful. Thank you so much, Dr. Ron. So as a reminder, our vision is to create a world where every patient can receive their life-saving cell therapy. We heard from Elias about, the foundation of who we are as an organization. Lexi shared some of the historical context into how we've gotten into situations that have created some of the barriers. And Dr. Ron talked about, that science behind how we match and the importance of the diversity in the registry to create those matches. So my role within the foundation at NMDP is to help raise funds in order to remove barriers where we can and can kind of control what we can control. So we've got a number of ways that we're able to lessen the load on our patients and make sure they're able to get to transplant and recover well and not have as many obstacles in their way. Next slide. So we have about 18,000 patients diagnosed each year. We are not meeting that demand as we have shared in the past, but we plan to. We've got a lot of wonderful growth plans and ability to register and raise the commitment of our registry members. But on the side of our patients, we really want to, again, make sure they're able to get to transplant and recover efficiently. So some of the major barriers to transplant that we are able to help control here at NMDP is meeting the need of more HLA matched donors. So we have been participating and leading some wonderful research studies, Donor for All, or our mismatched unrelated donor research. And what that has been doing is taking our donors that may not be an exact 8 out of 8 match and looking at the data to see if those outcomes are good enough, are worthwhile to explore, and so that our patients are able to receive that mismatch transplant. A lot of that research has been done, and we have been very successful at having additional support methods through medications and treatment plans that have showed that, yes, we can create these mismatched pairs and have very similar outcomes to an ideal matched donor outcome as well. Another barrier is the lack of referral to transplant centers. So we've recently rolled out our Pathways to Transplant program, which is our community physician engagement. So we have team members that are working with physicians locally to educate them more about the process of diagnosing these illnesses and getting them over to our transplant centers where we're able to fully support that pathway. Financial constraints, we've talked about that a few different times. One of the large areas of our organization within the foundation is our patient assistance grants. We are able to help those families before, during, and after their transplant process in a number of ways. And then lack of awareness. Through our patient education and navigation support, we're able to connect with our patients, connect with caregivers, and offer social work services, therapy services to really help make sure our patient support system is also as strong as it can be to help support their transplant journey. And then mental health challenges certainly can be a barrier to transplant as well. And we have a patient and caregiver emotional support program called PACES, where they are, again, given no cost therapy and treatment to help navigate through the transplant journey. Next slide. So we mentioned patient assistance funding. I wanted to explain a little bit more of what that means, because the transplant itself is a costly option, and we want to make sure that outside of the walls of the hospital, we're able to support them as well. So our patient assistance funding covers things like housing, because they may have to move into temporary housing based on where they're being treated. Food support, it's about $100 for every 2 days of meals away from home. And there are specific diet plans that must be followed and unique situations that could come up to raise those costs. Clinic copays, we want to make sure that that's not a barrier to transplant. It is a lot of medication and office visits, and we are able to help support covering some costs of those copays as well. Next slide. And it's wonderful to be able to hear from our transplant patients and grant recipients. So wanted to share Mateo's story from his mother, Amanda's point of view. So Mateo was a stem cell transplant recipient. He's the little guy in the middle in the upper left-hand corner with his mom, Amanda, and dad, Jose. And then the bottom picture is Mateo with his mom, his dad, Jose, and his sisters. And so from Amanda specifically, she said that the grant helped us tremendously as we were behind on every bill possible. It helped us come out of the rut, and we are forever grateful. We were at risk of losing our house and power. NMDP helped our family with both children, and we were so grateful. And this is just one out of tens of thousands of patients we've been able to help, and wanted to make sure we shared this story as a thank you for you all offering your support in attending this webinar and learning more about what we do, as well as the financial support that we receive throughout the years from various ways, whether it's individual giving, corporate giving, grants, a small amount of government funding, all to make sure the transplant journey can be as positive an outcome as we can. I think I'm giving it back to Dr. Ron.
Thank you very much, Rebecca. So, and you can go through all of them. Yeah, that's perfect. Thank you. I was one of the lucky ones who have been able to go visit our team in Mexico. And yes, NMDP has a team in Mexico. If you heard what Rebecca said earlier regarding our vision, it is a global vision. She read it. Create a world where every patient can receive their life-saving therapy. And so NMDP decided, how are we going to impact the world? How is this vision going to be global? And we started a registry in Mexico. And I was lucky enough to be down there when they celebrated their anniversary, and it was our 5-year anniversary, and they brought 3 donor recipients, 3 pairs, and they were all donors from Mexico for recipients within the country. And we are now celebrating 7 years. There are over 200,000 members on the Mexican NMDP registry. Over 4,000 CT requests have been facilitated. And now we're almost at 600 workup requests and collections, almost 300. 113 patients transplanted in Mexico. I mean, that is incredible for the work that we've done there. Next slide, please. Alternate donors and sources improve lives. We know this, especially for patients who are ethnically diverse and racially diverse. I don't know if you can tell, I am of a diverse background, and this is very personal to me. And I'll get into it in a little bit. If we go to the next slide. I discussed the studies that we have done. Well, this is one of the greatest advances that we have made when it comes to hematopoietic stem cell transplants in the world. For mismatched unrelated donors, we have found that NMDP has done a sponsored study using post-transplant cyclophosphamide, so PTCy, to treat blood cancers and prevent graft versus host disease for mismatched unrelated donors and transplants. And what you see here is, if you look at that first bar, for a Black African American to find a match in the registry at an 8 out of 8, it was 29%. But if they are looking for a 7 out of 8, if you could click the next slide, I think it'll give the exact numbers. It's about 8, there you go, 84%. 84%. Now, with this PTCy treatment to address any GVHD that would exist by doing a mismatch, we are now ensuring 84%. Now go click it one more time. Look at the numbers now if you do a 6 out of 8. These are the advancements that NMDP is making historical advancements to ensure that this treatment is equitable across the board for everyone and that our global vision is met. Next slide, please. Expanding the pool for a 7 out of 8 match increases the likelihood, and it's actually by 10 times for patients who are diverse. And I'll leave you with this. I mentioned that I started as a volunteer many years ago for a friend of mine who was diverse. And unfortunately, he did not find a match, and he passed away in 2008. And I often think when we have moments like this, when we celebrate all the transplants that we facilitated, and when we celebrate things like this, where we can now do these mismatch unrelated donor transplants, I think about him and I go, I wonder, would he have had a match? How many 7 of 8s existed back then for him? How many 6 of 8s existed for him back then? I don't know. But it's comforting to know that there will be other families and friends who won't have to wonder anymore because of these advances. Thank you again for listening. I'd like to pass it off to Lexi.
Thank you so much, Dr. Jacob, for walking us through all of that and sharing your connection to our work too. So at NMDP, we have an incredible diversity of thoughts, perspectives, experiences that inform our work. We each bring something unique to this space, and it helps inform how we expand access and help save lives. The reality is how we show the reality is how we show up in the world is informed by our positionality. Positionality is made of two parts: the social and political context that creates your identity, and two, how your identity influences and biases your perception of and outlook on the world. So it's two parts. It's not only how you're seen by the world, but how you see the world because of it. It's made up of our race, wealth, gender, sexuality, nationality, ability, language of origin. So many different components make up our positionality or identity. And so we're going to do an activity where we think about what our positionality is, get that mentee out again. Again, it's 100% anonymous, and it's the same link as before, so it should be up if you had kept the website up. And so which identity do you think about the most? Oftentimes, we don't think about our identities. We show up to the work the way we show up to the work, but all of us consider different things primarily. So you're able to pick up to 3, or at least you should be. If you can't, you can just pick 1, and that's okay. And I want you just to share which one you think about the most. I see it slowing down a little bit. And then my next question for you is, which identity do you think about the least? What doesn't come to your mind? Okay. And which identity most impacts others' perceptions of you? When you show up in the world, what do people see first or think of first? And so, what parts of your identity are you most proud of? What do you show up with pride and are excited to share with others? Love. And I love how these are things that weren't listed. Because the reality is the things that we think about when it comes to our identity, our positionality, aren't often check boxes on a list. It's the things that we show up with that we're most proud of, that we know carry us through the day to day, despite what the world might see us as. And so, my question to you are, what are your reactions to hearing this? Have you ever considered these questions before? Have you ever considered how you show up in the world and how that might be different than how other people see you? I'll give a quick moment and then we'll go back to the PowerPoint. Great. And what I love of this is that, sometimes we don't even think of these things and we realize we walk through the world without even realizing it, but knowing that it's at top of mind until somebody puts it in front of us. Great. Okay, I'm glad you guys like this activity. And again, if you're at home watching this later, definitely think about this and reflect on it more. The great kind of thing to talk about too with people of different perspectives than you is seeing what they consider first. And so what we know and what we really have just settled on in this whole conversation is that health access disparities have complex causes, and no one can solve them on their own. You won't be able to solve them when you're one on one with a patient. We can't solve them by ourselves with one case, but we know together we can make transplant more available to the patients who need it. And so at NMDP, two of our core principles are expand access and world class partnership. We believe that to combat these transplant disparities and expand access, we have to do that through world-class partnership. And so Matt's going to share with you a little bit of how we're partnering with students like y'all to achieve these ambitious goals. So Matt, I'll hand it off to you.
Excellent. Excellent, Lexi. Thank you so much. And happy Friday afternoon, everyone. Thank you to my esteemed colleagues that have joined me for today's presentation. Whether you're watching it live or recording, or watching the recording, we're glad that you tuned in and that you've absorbed this information so that you can help be part of our life-saving movement to make a difference. So NMDP does have a number of partnerships that have been established out there. And it was actually back in 2018 when we first started having paid interns on historically Black college and university campuses. 2018. And throughout time, the number of campuses and maybe some of the campuses have changed here and there. But this is a program that we are proud of because these students are our advocates. They are an extension of our staff and team, and they are helping to spread awareness on their campuses with predominantly Black and African American individuals. We also have a National Student Leadership Board, and this board was started in 2021, 10 years after we actually started having campus chapters across the country on college and university campuses. So you can see this picture here of many of our HBCU interns and some of our National Student Leadership Board. We also have members of some of our campus chapters that did exemplary work this past academic year when they all assembled. And this is on the rooftop of the the rooftop patio of the very building that Elias goes to in Minneapolis daily at our world headquarters. Next slide. We also have a number of college partnerships. And as you're reading through the list of these, I'm just going to highlight a couple of them to provide a little bit of context and background. Some of you are maybe familiar with many on this list. SAMHSA, CAMHSA. Many of you might have been members of HOSA when you were in high school or in college. The top two on the list, APAMSA, the Asian Pacific American Medical Students Association. We actually began partnering with them many years ago when one of the founders of that organization their family member was diagnosed and needed to find a match in an unrelated donor. And then that next bullet there, the College Band Directors National Association, it was actually a member of a marching band who was diagnosed with a blood disease and disorder that did not have a match. And that really sparked marching bands from across the country to pick up and answer the call and to join our movement to help spread awareness with their student members. And think about those sizes of marching bands across campuses. You know, some are 200, some are 400 big. It's a huge way for us to be able to have an impact, but also to educate young students that joining the registry is something that could have an impact in the short term, but it could also have an impact in years to come. Next slide, please. We also partner with a number of Greek organizations on campuses, fraternities and sororities. And again, I'm going to pick out two here. Partway down through the list there, you see Farmhouse Fraternity. One of the founders of Be the Match, Dr. Robert Gray, Be the Match, our former name, one of the founders of NMDP, Dr. Robert Graves was a member of Farmhouse. And it was his daughter who was the first to receive a transplant, a marrow transplant from an unrelated donor. And this was all the way back in 1979. Now, if you remember one of the very first slides that Elias covered when we started, we actually started as an organization. We're founded in 1987. So this first transplant with an unrelated donor for Laura Graves, his daughter, out of love, he worked tirelessly in building this registry with files and information on his own, way before technology. And how that has come about today and impacting the number of lives we have today is significant. Now, that number, 1979, that year, sadly, that was 2 years after my father passed away. He was diagnosed with leukemia when I was just a wee one. And this was way before the registry existed. So he didn't have the opportunity to receive a life-saving cell therapy and a matching donor because there was no match within the family. The other organization I'm going to highlight here too is Lambda Phi Epsilon Fraternity, an Asian American fraternity with chapters across the country. They started working with us when one of their brothers at Stanford University was diagnosed. And literally Lambda Phi Epsilon Fraternity helped over 10,000 individuals join the registry within a matter of months back in the 1990s. But we value and cherish each one of these partners that work with us. Some of them have been decades, some of them may have been months. Next slide. And because of our world-class partners, we are in tune and dialed in to deliver the best service possible because we know that that will make a difference for the patients that we serve day in and day out. Next slide. And I'm very happy to announce here that AMSA and NMDP are now official partners. Thank you to the folks at the American Medical Student Association, to the folks that already have put our logo up on the AMSA website as a strategic collaborator. We are very happy to be joining this new era because we know the collective impact that we can have together can help so many, not just within the United States, but around the globe. Next slide. And really, this is not necessarily just starting off. We're getting a running start here because thanks to the folks in our data and informatics, we were able to scour our files to see, hey, how much do we know we've actually worked with AMSA historically? We were able to identify 53 different NMDP registry awareness and member recruitment events that have occurred between 1999 and actually just as recently as a couple of weeks ago at a campus out in California. And these events have added over 1,800 new members to the registry that have joined at these 53 events. And from those, you see two different numbers here. There have been 14 donations made from these individuals that have joined when we've collaborated with AMSA on an unofficial and singular basis on individual campuses. And then that last one, the 13 unique donors, well, that's different from the 14 because one of those donors is actually donated twice. And it is possible for an individual, because of HLA typing that we heard Dr. Ron talk about, it is possible for a donor to match with more than one patient. It happens, and we're grateful for it. Next slide. So what next? What can you do? What can we do together? We want as many AMSA members, as many AMSA alums, as many AMSA chapters to be able to get involved with our life-saving movement. And you can scan this QR code here. It's a simple name, where are you at, what campus, what chapter are you at, how would you like to get involved? and we can connect you with the NMDP staff member. We are fortunate to have staff members located across the country that do this work, but we can't do it alone. That's the essence of the partnership, right? We need volunteers, we need organizations, we need young individuals that are inspired, that want to make a difference. And this can be everything from hosting presentations for your AMSA chapter, scheduling events, assisting with campus events that we have on your campuses, volunteering individually, or maybe you want to do them more than just being a volunteer. Maybe you want to become an ambassador. So if you could go to the next slide, you're not going to miss that QR code because it's going to be remaining up here on the next couple of slides as well too. I mentioned before, we have these NMDP campus chapters. We have registered student organizations on 122 that are actually active, 122 campuses this academic year, right? And our chapters that are out there are designed to assist partner organizations like AMSA, right? We want to be an extension of your group and be there side by side to do this work with us. Now, according to AMSA's website, there are 550 chapters for AMSA in the United States alone. Can you imagine the potential impact we could all have if even just half of our NMDP chapters and just half of the AMSA chapters collaborate together? Imagine the awareness we could spread, and imagine the number of new members we could add to the registry, and the amount of hope that we can provide for patients and families who don't have a matching donor in their family. Next slide. The other way that you can get involved in the movement, join the registry. If you haven't joined already yet, we would love to have you. And hopefully after watching this recording or sitting in live, this is something that you feel called to do. Now, the QR code that you see within the phone there, that's the one that you're going to want to scan to join the registry. You can also text AMSA HEWA, all together, AMSA HEWA, to 61474. That's AMSA HEWA to 61474. This join code will be active for many months, so you don't have to worry about doing it within a certain time. And to join the registry, you just have to be between the ages of 18 and 40. You need to be a resident of the United States or one of the territories or freely associated states, and you need to be able to meet the medical guidelines. It is very simple to do, the process to request it, and this will actually have a swab kit sent to your home. So when we partner with groups like AMSA and our other partners at live events, you can swab in person on site. This will actually have the swab kit mailed to your home so that you can send back after you finish reading through everything and that you've made the determination to be a committed donor. Next slide. Last but not least, you can be part of our life-saving movement if you're coming to Future Physicians for Change in Washington, D.C. April 17th through the 19th, we will be there, and we're very happy to be able to be there this year. We will have an exhibitor booth. We're also hosting an expert session, and we'll also be present at the pre-health fair, knowing that there might be many undergraduates and pre-med students that might be at Future Physicians for Change that want to carry this back to their campuses and with their communities as well too. Again, that QR code to get involved. And actually, I'm getting the email notifications that a couple forms have actually been submitted. They're popping up on my screen. Thank you for hosting, Lexi sharing her screen, because on mine, I'm seeing them pop up with some of them coming in. And that makes me feel so fantastic. Next slide, please. We'll show a couple minutes of this video here, which is very interesting because, well, you will see. No spoiler alert from Matt. Lexi, take it away.
You know, living with a disease like this, you're unable to plan for the future. I was in and out of the hospital every other week, staying in there for weeks or months on end sometimes. My identity was based around having sickle cell. I thought that it would be something that took my life. I always thought about my son and him having to grow up without a father.
When I told my daughters I was donating, they asked why. They were too young to really understand. And I was straight to the point. I said, I'm trying to save somebody's life. What's going on, fellas?
What's
up, man? What's going on? Hey, how's it going? Going good, man. Good to see you. Good to see you too.
You each have like such incredible resilience that I think is amazing, that we don't get to often see from both the patient and also the donor side, that I wish that in medical school we got more of.
From the time I found out I was a match, I didn't know, honestly, how much time that person had left. It's almost like you're seeing an hourglass flip up and it's going way faster than it should on somebody's life, though.
Hi, Daddy. This is me, Landon. I know you can't talk because you're not feeling well. And I was here to say good night.
Landon's mother passed away in 2016, so when I had the doctors telling me that, you know, I'd probably live until the time I'm 35 or 36, the way my sickle cell is going, I mean, it killed me, because if a doctor tells you something enough times, you're gonna believe it. If anybody tells you something enough times, you're gonna believe it. I got my transplant March 2019. Words can't even describe what they did for me in my life. The impact on me and my son's life was just amazing.
So I know one thing that keeps a lot of people from wanting to help out in the medical system, whether that's giving blood, etc., is a fear of the past and things that have been done to the Black community specifically. I'm curious, was that something on your mind when you were going to give?
Oh, it definitely was. I understand the distrust between the community, medical community and the Black population in America, but everybody has that ability to research. I believe just understanding the right people to talk to is the key to doing that, though. If you care about, you know, the people that are specifically in your family, you know, in your community, it behooves you to actually be a part of that change. I don't think you ever stop being afraid of stuff. I just think you have to understand that sometimes you gotta have the courage to kind of just walk through it.
And that concludes our formal presentation. Thank you for everybody who's tuned in, both live and if you're watching the recording. We now have ample time to take any sort of questions from the audience, any sort of discussion topics. Keep those interest forms coming in as well too, knowing that it's being live streamed. I'm sure some of the people submitting them probably aren't even on this Zoom call either. So to my colleagues that put in their time to help with this presentation, thank you so much. To the folks at AMSA, thank you for such great conversations over the past several months that have led us to this point, that has us here today, and that has us partnering in this very strong way to save lives through cell therapy.
So we open it up for questions. I want to take a moment on behalf of AMSA to thank you so much. You hear my voice quivering a little because I'm still recovering from that video and the whole presentation. I think many of us are, and many of us will be as we continue to watch this. We want to thank you for being partners, and thank you for how lovingly you created a presentation and your work is so comprehensive that you take time to go through the very important and necessary history, and then also bringing in current cases, your impact, which is of course global, and of course your personal sentiments, how the organization has impacted you and your own people in your lives who have been affected by these diseases. So thank you so much from the bottom of our hearts. I'm sure it's clear how this fits into our framework and into our work as we think about inequity and increasing access and increasing life-affirming practices. So thank you. And yes, let's open the floor. Please feel free to use the chat or unmute. We have Colleen thanking you guys and said it's a wonderful presentation and partnership. She has to hop off, but she's thanking you. Caleb, yes.
Hello, I hope you all can hear me well. I really want to echo everything that Danya said. This was truly an amazing presentation. The intentionality, the compassion, just genuinely everything was just beautiful, and I really appreciate it. And I guess my question, I'm going to figure out what exactly I'm trying to say as I'm asking it. But I'm curious about what different ways have y'all gone about? I'm kind of going off separate, I guess, from one of y'all's missions, but um, I think that the way that y'all really presented this is something that is needed, especially in college environments. And so I'm very happy to see all of your partnerships and everything. But I'm just kind of curious about what does engaging with college students and helping teach them and educate them on how they can have these can be very heavy conversations, but are very necessary. What do those kind of look like? I don't know if that makes any sense. So I'm just kind of curious about what does the collaboration with either medical students, pre-medical, look like whenever you're trying to, whenever they're pushing on your efforts. But yeah.
Matt, do you want to touch on the partnerships, and then I'll discuss how they're reflected?
I sure can. I knew you were going to be the first one to come off mute, Ron. Great question, Caleb. Thank you. So we collaborate in many different ways with our partners across the country, both in large group settings and in individual settings, right? We want the biggest thing, and this is something that NMDP is focusing on tremendously, is not just having people join the registry, but making sure that they are educated and committed, right? The last thing we want is to be able to have, or to have to tell a patient and their family that there is no available donor. Even though there may be somebody with that HLA typing that might be a 8 out of 8 or 7 out of 8 match. And so the education component for it is extremely critical. And we're constantly innovating to make sure that our staff and our volunteers are doing all that they can to be able to share end to end what it's like to be on the registry. And if you do come up as a match for a patient, what that donation process is like, and assuring them that as a donor, they will not face any financial hardships, right? That's what Rebecca talked about with the financial assistance and grant support, right? We make sure that we are there to support them every step of the way.
Caleb,
Ron?
Thanks, Matt. Caleb, my team is responsible for the education and enrollment of new members to the registry on the East Coast. And just like my team, we have a Central and a West as well. And those conversations are extremely unique because sometimes when you speak to someone who's pre-med or in medical school, you know their background. They kind of understand where we're coming from. I think it is difficult when you're speaking to someone in undergrad who is just, maybe if we're at a tabling event, they're just walking by, you're trying to grab them and catch their attention. That is a lot more difficult than if we have a room of 100 people where we have the opportunity to do a presentation, right? So our approach and strategy is the same both ways, is engage them, educate them, enroll them. Right. And so that really is the approach. How do we just get them to come over if it's a tabling event? And then how do we then take that 5-10 minutes to really teach them this is what it is and this is why we need you? And then do that assessment saying, okay, does it seem like this person would be committed? Would you be willing to add yourself? I would love it if we can be in front of 300 people in a lecture hall where you would hear this same presentation and when we're done, we hand out our swab kits and you have a QR code and you just register right then, 5 minutes on your phone, not even, it's like 3 minutes now on your phone, and a swab that takes 20 seconds and you're done. But knowing that all the questions have been answered, knowing that they are confident with the information that's been provided to them, so that when they get that text message or that phone call or that email saying, hey, you've come up as a match for a 15-year-old boy or a 35-year-old woman, and they see NMDP and they go, oh, I know who that is. And they're excited and thrilled to be part of that. So we, as Matt said, we're looking to partner with medical schools, orgs, clubs, and even undergraduate chapters, and undergraduate organizations to be able to do this. As I mentioned, I'm here. I'm in New York, and there is a campus here, NYCOM, New York College of Medicine. And the director of that program, what he does is he invites us every other year to do a presentation so that he's got two full classes sitting there in that auditorium, and we do the presentation, and then we have the opportunity to register all of them. Right. And he's strategic. He's like, you're not coming every year. You're coming every other year. You know, we have other groups that will, because he knows the impact is you've got everyone now. Right. There are other groups that don't have that capacity to do that. So they do tabling events 2 times a year, 3 times a year, collaborate with other groups. So, but as Matt said, it really is about educating. You know, we didn't really get into the whole transplant process here, but PBSC versus marrow. People don't understand that PBSC exists, that 90% of the time it's peripheral blood stem cell collection versus marrow. Most medical students don't. I didn't. When I was a second-year medical student and my buddy was diagnosed, I had no clue that NMDP existed. I went to we used books back then. I know you guys don't use books anymore, but we used textbooks. I flipped through my pathology book trying to find out something. There's one little paragraph that said a hematopoietic stem cell transplant is a curative option or treatment. So that was it. Nothing beyond that. And I was kind of embarrassed. So these are the opportunities. And I can't say enough. I was thrilled when Matt told me about this partnership. I put out that t-shirt and it was way too snug. And my colleagues still have that picture. They're going to blackmail me with it one day, I know. But it's a proud moment for me. It really is. So I hope I answered your question.
Thank you guys. That was great. Genuinely. Thank y'all.
There was a question posted in the chat. Oh, sorry, Danya, you may have been saying what I was
that's
just gonna
great.
say.
I was going to do exactly that. So continue, please.
Well, and Ron, this is actually in your backyard in New York. The New York Senate passes a bill to expand marrow donor pool, aiding blood cancer patients. It looks like this is also just fresh and recent, just a couple of days ago. So, and it looks like just based on the article, this is something through the DMV, which is something that we do have active in a few other states across the country as well, too. So. Yes,
and actually, I just heard that. Full disclosure, I was in Washington D.C. on what day was it? Monday, Tuesday, or Tuesday, Wednesday? The whole week is merging together. But I was just there with my colleagues on Capitol Hill, going and meeting different Congresspeople about NMDP. And while there, that's when I was told about this initiative. So yeah, that's another aspect of what we do at NMDP. We are out there with our government affairs department, really advocating on behalf of us and our patients and pushing through legislation like that and initiatives like that. So thank you for recognizing that. Appreciate it.
The other thing that I just throw in and add there is it relates to legislative and advocacy work that's a little bit different, but also something that undergraduate and graduate students can be part of, is that I mentioned before our 122 active NMDP chapters across the campus. Some of them are sparking up developing donor leave policies for their campus, so that the process for a student, that if they get contacted as a match, so that there's an institutional policy that helps protect the student donor from any negative academic repercussions. So this is exciting, and it's something that's literally brand new starting this semester. A couple of our partner organizations that we work with are also taking on this opportunity. And as we continue to establish and grow our partnership with AMSA, this is very likely something that we could potentially open up to some AMSA chapters to collaborate with. If it happens to be a campus where there's both an AMSA chapter and an NMDP chapter, we would want them to join forces so that there's one singular voice. But we know there might be some AMSA chapters where NMDP doesn't have a presence on that campus. And if they have the fortitude to be able to do this and work with university administrators, that is something that, in addition to enrolling new members on the registry, could have and should have a lasting impact, not just for those students that are swabbing and joining the registry that year, but for years to come.
I'm hearing a lot of potential here for things like advocacy toolkits that, I've been really learning a lot about the word toolkit lately through this role. Very powerful, can mean a lot of things. I've come to find it's very versatile. But the creating things like this that we can, place on our landing pages, and we have various like committees that work hard to advocate for like specific issues, but we could even, create advocacy toolkits surrounding this, deploy them to chapters, a way to really enhance like that partnership. So, but other questions or reflections? AMSA does love a toolkit. It's very true, Caleb. Many. Looking for more. Well, I have a quick reflection while maybe someone can think about some of theirs. I'm wondering, it's so powerful to hear, Dr. Jacob, that you were also an AMSA member, and I think like it gives us too, as current AMSA members and advocates, kind of this like long-term vision, right, of what it can look like, as practitioners, how we can be involved in this work. And I'm just kind of curious a little bit from your side, how did being an AMSA prepare you to kind of be involved in something like this, or did it?
It did. I think through AMSA, especially the initiatives were at that time. I remember being part of initiatives of those health fairs and trying to support the populations that didn't have access to the kind of care and things like that. I think that really was something that's been around with AMSA for decades, right? And I'm so appreciative of that. I think that's the compassionate work that AMSA does. That again, when Matt told me this, I said, "This is perfect. This partnership. This is exactly what it is." Knowing that my future colleagues like you are going to be out there and serving and pushing our mission and ensuring that, I'm thrilled. The other aspect is when we do events, unfortunately, some of our worst volunteers are physicians, and I laugh at and say that because sometimes they think they know it, but they don't. And it's understandable. They don't know about the transplant process. They don't know about, well, as I mentioned, PBSC versus marrow and the differences in that and all that. So I think from your perspective is to go in there knowing that there's always opportunity to grow and there's opportunity for you to expand. And I think this is something where I am confident that you can go in there and dispel the myths that continue to perpetuate within our communities. And that's what I need everyone on this call in this organization to do. Be those ambassadors that go in there and ensure that we are sharing the proper, appropriate information, and take care of those who might not be able to have what they need and that opportunity, right? That's where I really push for. AMSA should be the voice for the voiceless, and you continue to do that. So thank you.
Thank you so much. I love that, the voice for the voiceless. And I won't hijack if anyone has other reflections, but I want to mention that I think that's so powerful, and a lot of what I think our advocacy arm or what we're building and rebuilding in a lot of ways, what we're working to communicate. One of the tenets, if I can so speak for this, I guess in my own experience so far with AMSA, is starting early, like you're saying, right? So it's like if we can educate you at a college level, at a pre-med level, and then onwards, can you imagine? I mean, if I knew some of these things earlier, just the amount of time that we could, get back in a way, right, to prepare advocates. And, even earlier today, I was giving a brief talk about calling Congress. And thank you, Becky. I want to shout out Becky Martin, who is truly our advocacy leader in so many ways and has helped me so much in this way, because I was new to a lot of this stuff. And that's what I mean when I say take time back, or getting it back. I wish I had known more, because I've been learning so much in this role. And a part of that was, speaking to these pre-med students and, them even learning how to go and find their representative to call, right? To know about some of these issues, to then call and say, I want to oppose this, or I'm for this, to even ingrain someone with a sense of urgency that once we are physicians, we are obviously the training for a physician is so important and the clinical aspect is key, but what are we missing in the classroom? And a lot of what NMDP, I believe this history teaches us, and other initiatives that we work for at AMSA in our academy, is a new kind of classroom, right? We're supplementing you with the things that maybe you're not seeing until you're seeing, and then what then? And so how can we prepare you? So anyways, thank you so much. Other thoughts, reflections? Takeaways? Well, I'm sure we will be reaching out with many. We hope to partner with you consistently. I mean, we are already partnering, but when I say that, I mean, I hope we can have you back in this form too, and continue to promote your work with our students. And I believe your contact info, I don't know if anyone would be willing to share some of your contact information. It's okay if not. Maybe we could put that in the chat and someone could reach out if they have questions they don't feel like sharing, or reflections they don't feel like sharing publicly. Thank you. Well, on behalf of AMSA, I just, words fall short, words fall back. Thank you for your work. Thank you for the passion that you bring, the personal narratives that you bring. I'd love to take a moment to also allow Tanushree to introduce herself as our committee chair. I know she'll want to say hi.
Sorry that I joined a bit late to this meeting, but it's really good to hear from you all. And I saw on your map that you had like one, so I'm sorry, I'll start from the beginning. I'm Tanushree, I'm a first year med student. I'm zooming in from Alabama. And I saw that on your map, you had one school in Alabama that has an NMDP NMDP chapter. So I'll definitely be checking to see if that's my school. And if not, I will definitely be reaching out because this sounds like a really cool opportunity. Thank you.
Thank you so much for mentioning that. And even if we don't have an NMDP chapter on your campus, we have staff that cover every state in the United States. So you can schedule and work with them without the presence of a chapter. And actually, we've had a couple just this academic year, a couple of the new chapters that have been started across the country for NMDP have been spearheaded by AMSA members.
That's so cool.
So there's a lot of synergies already happening on an organic level.
That's a big responsibility.
I think you'd do great. That's wonderful. Thank you, Tanushree, and for all of your hard work and helping to coordinate this amazing event. And I'm sure people that are streaming in will have questions that they can't necessarily type in. So I'll make sure to be mindful of those and the ones that were able to watch this and taking note of their questions and leading them your way or answering them if I'm able to myself. But thank you all. If you have any closing comments that you'd like to give, but I just want to, on behalf of all of us, we look so forward to the future and seeing you in person soon.
Indeed. Thank you.
Thank you, everyone.
Thank you, guys. Have a great Friday.
You
Thank
too.
you.
Thank you. So good to meet you guys.
You as well, Danya. Thank you for everything. We appreciate it.
Gosh, it's been so nice. What am I going to do without our emails every day? We'll have to keep up.
Oh, I'm sure you'll find somebody else.
Thank you. It's been nice.
Yeah, indeed. But we'll see you in DC in April.
I can't wait.
Awesome. Thank you.
Thank you. Bye.